As I suspect Dr. Conti just said, my name is Scott Damrauer. I'm a associate professor of surgery and an associate professor of genetics at the University of Pennsylvania and the Corporal Michael Crescenz VA Medical Center in Philadelphia. I am really honored to get to talk about precision medicine and vascular disease and help set the stage for the discussions that are going to happen throughout the day today. I'm pretty bummed I can't be there in person. I was really looking forward to it, as I think the agenda is amazing, and this is a super important and interesting topic. Unfortunately, I came down with COVID just as I was getting ready to head out to the meeting, and so I'm not able to attend in person. I'm really thankful I'm still able to record this and share my thoughts with you and hopefully set a foundation upon which the presentations and discussions today can build. These are my disclosures. They're largely irrelevant other than the fact that I am a co-inventor on a VA filed and owned patent relating to the use of polygenic risk scores for VTE prediction. What I'm hoping to do today is really touch on two things. The first I think about is, where are we going? What are the promises of precision medicine, and how will they help shape, or how can they help shape, our care of patients? And then the second, are we there yet? What have we done to get there? What are the challenges we've encountered? And how can we focus our efforts? So with that, I think that there are three main endeavors in medicine that can ultimately be improved through the use of precision approaches. The first is represented here, and that's when faced with a large group of individuals, we have this fundamental interest in identifying those at highest risk and those at lowest risk for the disease that we're interested in, so that we can institute appropriate primary and secondary preventative measures and hopefully affect not only the lives of patients, but population health overall. The second is represented here. When faced with an individual patient in the office, in this case, a 65-year-old with new onset claudication and mildly depressed ABIs, we have this fundamental question of what's going to happen to them in the future and how their disease may or may not progress. What we really want is the ability to shake our magic 8-ball and have it tell us whether or not they're going to have stable intermittent claudication at 83, CLTI at 73, or die of an MI at 78, so that we can counsel them, institute appropriate therapy, and really care for them, knowing what they are at risk for in the future, not just average statistics. And then the third is represented here, and that is really trying to identify the differences between seemingly similar disease in different patients and institute therapies that treat that specific patient and the disease as it is in that patient. Sometimes it's easy to spot what makes one individual stand out from a crowd. Sometimes it's more challenging to tell the difference between two highly related things. As an aside, looking at this picture, I can tell you I've at least been able to see the time is different, the bus numbers are different, and this guy's not wearing a coat while this guy's wearing the coat, but I'm sure there's more. Anyways, I think from my standpoint, this illustrates the uses of precision medicine, which are risk prediction for incident disease and disease progression, and then informing therapeutic selection. And I think if we can get there, we will really have achieved much of the promise of precision medicine. Now, that's great. I've thrown around the word precision medicine a ton. I think that doesn't answer what precision medicine is. And that's a little bit challenging because I think it means something slightly different to different people. The best definition I've found that resonates with me is paraphrased here from the NHGRI website, and that's the following. Precision medicine uses information about an individual's genome, environment, and lifestyle to provide a more precise approach for the prevention, diagnosis, and treatment of disease. I think this captures the full spectrum of what we're striving to do when we develop precision medicine approaches for any disease, and in particular for vascular disease. So are we there yet? Where are we with what we've done already, with what we know already, and how good are we at implementing precision medicine? I look at this through the view of common variant genetics, small effects from DNA variants that naturally occur and occur in most people. You're going to hear some wonderful talks later today from Dr. Diana Mielowitz and Dr. Shireen Shaloub, talking about more rare variant Mendelian forms of disease where genetics definitely impact outcomes as well, but our approach is slightly different. So I'm going to start with precision risk prediction. So as I said, a fundamental effort of medicine is trying to figure out who has disease. And for atherosclerotic cardiovascular disease, we largely do this through the use of the pooled cohorts equation. This is a kind of the traditional risk factors that allow us to calculate a 10-year risk of disease and then to sort people into different buckets of their disease risk and institute measures accordingly. And these measures largely are the use of statins, either regular or high-intensity statins, and either primary or secondary risk prevention thresholds for reducing LDL. Building on this approach, there's been a significant reduction in CVD-related death in the United States, or at least if I was giving this talk in 2010, that is what I would say. Unfortunately, over the past 3 years, CVD-related death has actually been increasing. There's a number of reasons for this, but I would posit that some of that is due to the fact that kind of our fundamental ability to predict risk is not as good as we think it is. So this is another risk prediction algorithm called QRisk3. It's one used more in the UK. It's a lot more complicated in the pooled cohorts equation. And even this, when assessed in appropriate data, only explains 55 to 60% of disease. So we're clearly missing something. The question becomes, what are we missing and how can we find it in order to improve risk prediction? I think a lot of people have posited genetics are the answer, and in particular, common variant genetics. And so these types of genetics come from genome-wide association studies. So we're testing the relationship between individual DNA variants that naturally occur throughout the genome and disease of interest. The results from such an experiment are represented by this type of graph called a Manhattan plot. Each dot represents an individual DNA variant. They're arranged on the x-axis by their location on the chromosome, and they're plotted on the y-axis by the negative log 10 p-value of their association with the disease of interest, which in this case happens to be PAD. And so what you see is these spikes that represent regions of the chromosome that very strongly associate with disease. And what I would point out is even the largest of these spikes here in the LPA locus only moderately increase your risk of disease, so 26%. And the vast majority of them have a pretty minimal effect on disease or increased risk of about 5%. Furthermore, there's a bunch of data below this genome-wide threshold that we call significance that likely confers very small amounts of risk. But what if we tried to sum all of this across the entire genome? We'd end up with the sum of a bunch of small stuff that might actually be a big risk. And so polygenic risk scores have been developed to allow us to do this. For the mathematically inclined, this is the formula. But essentially, you identify a set of DNA variants that you've picked and kind of pruned out based on their association with the disease and taking into account linkage disequilibrium. At each variant, you figure out whether the person carries 0, 1, or 2 copies. You multiply it by a weight or how much you think that variant increases risk, and then you sum it all up. And what you end up with is you can construct a very normal-looking distribution and begin to ask questions about people in the tails of that distribution. So this has been studied extensively for coronary artery disease, and here in 2 studies, both using UK Biobank data, we see those that at highest genetic risk have the highest risk of disease. Here, looking at the prevalence of coronary artery disease by risk quantile, and you see that if you're in the top 2.5% of polygenic risk, you have about a 4-fold increased risk for having CAD relative to people in the lowest bin. Looked at another way here, grouping people by their quantile on a slightly different score, which is a different way to combine the variants. You see those in the highest risk group have the greatest lifetime cumulative incidence of disease. So very strong association between polygenic risk and disease. Everyone was super excited about this. We thought this was great. This was going to revolutionize risk prediction. And then along came these two papers in JAMA. And I think these papers really used gold standard prospective cohort data and state-of-the-art methods for assessing risk prediction models rather than just testing the association of the polygenic risk score with the outcome controlling for traditional risk factors. They looked at model fit, calibration, discrimination, all of these things we want from a good predictive model. And the results were pretty underwhelming. And in fact, that's why they got published in JAMA, is because they kind of started to cause us to push on the brakes a little bit and realize that maybe this wasn't actually going to solve all the problems we thought. And that's really the take home from this very nice editorial here that I think summarizes where we are very well with polygenic risk scores for CAD. The specific example I want to cite is this study here that I was lucky enough to be a part of. This was led by Jason Vassie at the Boston VA and Peter Wilson at the Atlanta VA. They used data from the VA Million Veterans Program and compared the risk predicted by the pooled cohorts equation to that predicted by the pooled cohorts equation plus a CAD PRS. And really, while they see statistically significant differences in net reclassification, these are pretty darn underwhelming. We're talking about like NRIs of 1%. So, yeah, that's positive. Yeah, it doesn't, 95% confidence interval excludes 0, but I don't know that anyone's getting really excited about that. So that's a little bit challenging. I think this largely is due to the fact that we have pretty good risk models for CAD. So where do PRSs have something to offer? So from that same study, we now look by age. And as you see among younger and younger participants, there appears to be a larger NRI associated with using polygenic risk scores. Granted, the confidence intervals are wide, they don't exclude the null, but I think this suggests that among the youngest individuals, there's probably more value of the genetics. And that makes sense. The pooled cohorts equation wasn't designed to be used in 40-year-olds. It wasn't designed to be used in 30 or 20-year-olds. It's not designed to predict lifetime risk. It predicts 10-year risk. And so, if we can leverage the genetics in these populations, we can identify people at earlier ages and intervene earlier to prevent disease later in life. And I think that's, we're going to need a lot more studies, true prospective cohorts, but that's a really interesting opportunity. The second is deciding who's going to get expensive therapies and trying to figure out where the best use of some of these more advanced therapies is. So this is a post hoc analysis of the Odyssey outcomes trial. That was a study that randomized people to alirocumab, which is a PCSK9 inhibitor, or placebo for the prevention of major adverse cardiovascular events. And you see a larger difference in outcomes among those at high genetic risk as compared to those at low genetic risk. So suggesting that people who have a higher genetic risk of disease may derive an outside benefit of therapeutics. And certainly as our therapeutics become more expensive, this will become important. Finally, this work here done by folks at the Scripps, they developed an app that allowed 23andMe participants to pull down their CAD PRS, provided some guidance, and then asked them questions about how they felt about that initially and at 6 months. And pretty consistently, individuals who had a high PRS said they were more likely to actually take their statins now that they knew this, and more likely to discuss it with their cardiologist. So I think intriguing that people see genetics as really deterministic and more likely to affect behavior. The other area that I think PRS has an ability to really impact risk prediction is areas where we don't have as good of algorithms to identify those at risk. And so I'm going to illustrate this with abdominal aortic aneurysm and work that we've done. We all know that individuals who are, at least men who are 65 to 75 and who have ever smoked, or men or women with a family history, get a aortic screening duplex by CMS, and actually the VA has a similar policy to try to identify those with abdominal aortic aneurysms. Unfortunately, this isn't a great way to decide who should get them. This is some really nice unpublished data from Lizzie George at Stanford. She was kind enough to loan me this slide, looking at people who went on to have AAA repairs in VQI. only 40% of them are eligible to get screening based on Medicare or VA rules. Again, suggesting that our screening policies aren't really picking up the right people. So we thought we could try to address this using polygenic risk scores. We developed a polygenic risk score from a GWAS of AAA and MVP, showed in some data that I'm not showing you that very strongly associates with AAA, and then asked how we could employ this. And so we know from randomized controlled trials that if you have a population of individuals with a prevalence of AAA of about 6 to 7%, that screening efforts are cost-effective and valuable. So when you consider polygenic risk scores, those in the top 5% of all ages and sexes have a prevalence of 6%, and men greater than 50 in the top 5% have a prevalence of 8.5%. So if we, expand identifying people for AAA screening to include polygenic risk, we could be better at capturing who really needs to be screened. What about AI and machine learning? Clearly a hot topic, something that everyone is interested in. And then I think the topic of what will hopefully be some really interesting talks later today. The talks later today are going to focus on PAD, I believe. I just want to touch base on some work we've done in CAD to highlight, I think, both opportunities and challenges. Excuse me. So we set up a similar data study to the one I previously showed you, using participants from the VA Million Veteran Program who were free of disease at enrollment, and asked what happened to them over time, trying to predict major adverse cardiovascular events. We first compared using machine learning to pooled cohorts equation, or just a Cox model with those risk factors, but without changing the risk factors. And what you see is the pooled cohorts equation doesn't make it onto the graph because it does so poorly. When you recalibrate it in a Cox model, it does much better. And truthfully, none of the machine learning approaches do any better than just a Cox regression. But when you expand the feature space and really allow the models to take advantage of all the diagnoses in the electronic health record and all of the lab values in the electronic health record and all of the missingness and the richness, you see that machine learning models really start to outperform everything else. And so I think this emphasizes that they're not magic, but they really have this ability to deal with highly complex predictors. And by using highly complex sets of predictors, you can better predict the outcome. One of the criticisms of AI is a little bit of black box. It may be black box in terms of how it works, but you can certainly pull out either at the population level, as shown here, or on the next slide that I'll show you in a second, at the individual level, what the important variables were and how they affect the outcome. So you can generate for any one given patient what their risk is and how they got there. These may not be the same features for every patient, but at least you can show this to a patient and say, hey, this is why you have the risk that you do. So overall, in terms of risk prediction, I think precision medicine has a lot to offer, as I hope I've convinced you. I think that's going to be in population-specific models using expanded feature sets and machine learning. I think polygenic risk scores for select cases, young individuals, those where you have the genetics already and you don't have the risk factors, as part of some of these genomic population health initiatives. And for in our setting, vascular disease, but I think more broadly, areas where we don't have good risk models, but do have strong genetics, and we have clearly heritable traits. And then finally, what I didn't touch on, but I know others are going to be speaking about later today, are kind of how we can use other novel biomarkers, proteomics, metabolomics, the microbiome, to help predict disease, because I think this is all part of precision medicine. Switching gears a little bit, I want to think about precision therapy and how we can leverage these approaches to help pick how we treat diseases. So right now, we treat all atherosclerotic vascular disease very similar. We're focusing on a core set of risk factors. We have a host of therapies, some of which are getting very, very expensive, up to $500,000 per person per year for some of the new therapies being developed. We can't just blindly give every one of these therapies to every person. We have to figure out a better way of who should get what therapy. And so I would argue we need to stop treating all three of the diseases coronary artery disease, peripheral artery disease, and cerebrovascular disease or carotid stenosis and stroke the same. They're in fact different diseases. And we need to work on trying to sort out what makes them different and how we can treat them differently. And so my group has used something called Mendelian randomization, which uses genetics to simulate a randomized controlled trial and to try to establish causal relationships between non-genetic risk factors and non-genetic outcomes. We've done some really nice work here, led by Mike Levin, who's actually in the audience today and will be helping do the Q&A part of my talk since I'm not there, comparing the traditional risk factors between PAD and CAD. And you can see that LDL cholesterol and blood pressure seem to greater affect CAD, whereas type 2 diabetes and smoking have a greater effect on PAD. We've gone on to use more advanced Mendelian randomization to really try to dissect the role of blood lipids. And we see that in both CAD and PAD, apolipoprotein B containing particles are the likely causal lipid fraction, but that the likely causal ApoB containing particle is different between the two diseases. So for PAD, it's extra small VLDL. For CAD, it's large LDL. And you might say, oh my gosh, it's extra small, very large, and large, large. They're not really different. But in fact, we really do think of their biology different, and the extra small VLDL is much more of a triglyceride-rich lipoprotein. This is important because some of those very expensive drugs I just showed you actually specifically target triglyceride-rich lipoproteins and extra small VLDL over other particles. And so you can begin to see how you might pick one drug or another depending on what type of cardiovascular disease someone has. So, hopefully we can move to a paradigm like this, or are moving to a paradigm like this. And despite the fact that I just laid that out, I really think we need to move to a paradigm like this. Not only are the three major diseases different, but everyone has slightly a different shade of the actual disease they have, and can we develop patient-specific therapeutics? Our oncology colleagues have been doing this for a while. They biopsy tumors, they sequence the tumors, they find specific molecular defects, and then they give drugs that intervene on the specific molecular defect, and this has revolutionized cancer care. So can we do this in vascular disease? There have been a couple of people that have started to try and put forward frameworks. This is from a thesis of Andrew Buchler at Karolinska Institute. He has used AI processing of traditional CTAs of the carotids to non-invasively dissect out the plaque, understand the plaque characteristics, do stress and strain modeling, link all of this to gene expression profiles, again, obtained non-invasively through AI based on the images, use that all, feed it into systems biology, and try to identify what pathways and what individuals are dysregulated and the best points of intervention to help that specific individual. Another approach here in a slide that Ken Tron at Stanford loaned me, he has proposed a paradigm in which we use a combination of cross-sectional imaging and physiologic data to develop models and simulations that allow us to look at blood flow, stress, and strain within the aorta, then allow us to bring in different approaches to treating aneurysmal disease with different graft constructs, develop the one that works best for the patient with respect to flow, stress, strain, and has the least likelihood of failure down the road. Really intriguing ideas, obviously both still very, very early days, but I think these are some of the things we can think about in a future of precision medicine-informed vascular disease care. So to finish this out, I think the future of precision medicine for therapeutic selection is disease-specific paradigms for risk factor modification and pharmacological management, non-invasive assessment of patient-specific biology to inform risk and therapy, and patient-specific interventions based on patient-specific anatomy and physiology modeled with computer simulation. So I think lots to be excited about, lots of work that we're going to need to do, and hopefully those of us, or those of you in the room and me who's not in the room, can all work together to get us there. And with that, I'd really again like to thank Drs. Conti and Patel and the team from the Foundation to Advance Vascular Cures for inviting me to give this talk and really allowing me to record it and share these thoughts with you, even though I can't be there today.